Hi, everyone. Welcome to another episode of the Sarcoma Sisters. We're so happy to have you all here today. So today we have a very special guest who is not only an amazing pathologist, but actually a celebrity as well. We stalk her on Twitter all the time. So Dr. Valerie Fitzhugh, she is an associate professor and chair of pathology, immunology, and laboratory medicine at the New Jersey School of Medicine at Rutgers. And she is a pathologist extraordinaire, but she also has like 1 million followers on Twitter. And it's not really 1 million, but it feels like it when you're like Wendy and I, or I should just say me and only have a few. But it's because she always has such great messages out there and gives everybody such good information about all kinds of topics. So we're so happy to have her today. We're going to, first of all, focus on pathology because, you know, we talk all the time about sarcomas, but I think a real mystery to everybody, including parents, is what happens when they biopsy that tissue and what are the next steps. And parents and patients, like they never get to see or talk to the pathologist. We're the only ones that get that privilege. So we thought it was really important to have a pathologist on the show. So Valerie, thank you, Dr. Fitzhugh. Thank you so much for coming. And I think maybe we could just start out with that, with maybe just giving us an overview of what you do as a pathologist.
So I do so many things now, but so I'll limit it to the role of what I do with sarcoma, because otherwise I can talk about this for like 3 hours.
That is true, yeah.
So, one of my areas of subspecialty expertise is bone and soft tissue pathology, and that includes cancerous and non-cancerous conditions of bones, so bones in the skeleton, as well as soft tissue, so muscle, fat, tendons, ligaments, etc. A lot of my role is actually orthopedic tumors. So, if a patient is diagnosed, and unfortunately I diagnose a lot of children because that's where we see a lot of these diseases. But if a patient presents with a tumor and they've had all the workup and they've got all the scans, the imaging, they go see the orthopedic surgeon, they come in for a biopsy, whether it's done, under anesthesia in the operating room or if it's done in interventional radiology, I then get that biopsy tissue. And in that moment, I do a lot of things. The first thing we usually do is something called a frozen section. So we take a little bit of the tissue, we put it into, I like to call it goop. It actually has a much fancier name that I can't think of right now. But it's this almost like gelatinous matrix that freezes in the cryostat. So the cryostat is this instrument that has frozen, that freezes. It's a freezing temperature. And it freezes this block of tissue. And we cut thin sections from this frozen block of tissue, stain it all up, all these pretty colors, and then we look at it under the microscope. And that allows us to tell the surgeon or the radiologist in the moment of the procedure whether or not, one, they have enough tissue for us to do all the things we need to do, because sometimes we do need to do more. If they need to go back and get more, because sometimes they do. Like I have enough to make a diagnosis, but not enough to do cytogenetics or FISH or molecular testing as I need to do it. And occasionally I can actually tell them on the spot what the diagnosis is. Like sometimes it's just so obvious. So for instance, a lot of the osteosarcomas that I get, I would say 99% of the time I can tell them on frozen section it's an osteosarcoma. Mm-hmm. And it's usually because I've reviewed the radiology ahead of time. So I've looked at all the bone imaging, I've looked at the plain x-ray, the CT scan, the MRI if it's there. So I know how large a tumor is, the extent of the disease, whether it's going into the soft tissues from the bone or not. So I usually have an idea of how bad something's going to be before I ever look at a slide, because I review all the other information about that patient first, which is something that bone pathologists know we have to do, because the presentation on imaging and the presentation of the patient is as important as what's on that slide. And so, I either make my diagnosis or I tell them, I have enough, but I need to do some studies so I can tell you more. I'll call you when I have more ideas. And often, I hate to say, it's often in a frozen section situation, the orthopedic surgeon will know what it is because I tell them what it is. But they won't tell the family, of course, until they have that final report, because it's a frozen section. It's preliminary. Things can change. And we don't want to freak out families if I change my mind down the road. So,
right.
So the surgeons, we have a really great understanding about what, as a pathologist, I can tell them in that moment. And then we take all that tissue. Again, we do some special studies sometimes. So we'll do cytogenetics, look at a karyotype. We'll do FISH if I have a diagnosis in mind and I want to look at a specific gene. Sometimes we'll do a full molecular panel if that's what we need to do, depending on what the tumor is. And then I get, so we process all this tissue, we encase it in paraffin, cut what we call permanent slides and stain those. And then I can create a final diagnosis and a report. And then unfortunately, I would say unfortunately then the family gets the bad news, but the better news is most of the time it's not cancer. I think that's something that people need to hear.
Yeah.
Because I diagnose a lot of cancer and it's terrible, but 90% of the time it's not cancer, it's something else. So there is sometimes light at the end of the rainbow, although we all deal in some of the more sad areas of what we do.
Thank you for that. That's I work with the pathologists that I work with, and I know them, and I know kind of their MO and their style. And the previous institution that I was at, had a very close relationship with my pathologist. He was actually one of my committee members on my PhD thesis committee. And so obviously we had a great working relationship, but it's nice to hear, and I assume it's this way across the country, is that you guys are more than just the people that look at slides. You're looking at the physician clinic notes sometimes, you're looking at the radiology images. And a lot of times the pathologists that I've worked with, whether they be bone and sarcoma pathologist specialists, or we also had some great hematopathologists that look at blood cancers, you guys know a lot about treatment too, like a lot of times, and a lot about the natural history of the way these diseases present and progress. And so you're not just the people at the microscope, which is what I want people to know, that you are probably the most important person at the beginning of a sarcoma journey, is because I can't do anything if I don't know what type of cancer you have. I am absolutely crippled, and that diagnosis is so important, and there's so much that goes into it. And so I always tell my families, we'll get the biopsy, depending on the institution and the bandwidth that the institution has, it may be, 7 to 10 business days. And that's excruciating for families, and we all acknowledge that. But it's so important to get the right diagnosis. And some of these things that you were talking about, can you comment a little further about what that means when you stain? Like, does that stain, like, do you plop it on, and is it like frosting on a cake, you see it immediately, or do they need to set around, or like, why does it take, sometimes 7 to 10 business days, and sometimes even longer if it's a tricky diagnosis? So what goes on and all those things, and is there a stepwise process to that?
So I think it depends. I mean, even within the rare tumors, right? Because we're talking about bone and soft tissue. These are like the rarest of the rare things that people get. But even within the rare, there are things that are more garden variety. So things, like a high-grade chondrosarcoma or an osteosarcoma. I can turn an osteosarcoma around in 24 hours, to be honest. If it is what it is, and it's an obvious osteosarcoma. Now, within osteosarcoma, we know there are subtypes. So if it's like a small cell osteosarcoma where I may not have a lot of the tumor bone in my slides, then yes, I have to make sure, and it's a child, I have to make sure that's not a Ewing sarcoma. I have to make sure that's not a lymphoblastic lymphoma. So in that case, it may take longer because I have to do immunohistochemistry. I may have a karyotype cooking in the background, and karyotype can take, so growing the cells so that we can look at the chromosomes can take anywhere from 7 to 10 days to do. So that's where you get into that longer time period. If I'm really worried and the family's really worried, I can try to line up FISH, because if I think something is a Ewing sarcoma, for instance, I can FISH for EWS. And I can get that done faster than waiting for a karyotype. So, there are definitely things that I can try to do to push the diagnosis out faster, particularly if I know what it is, it's going to come out fast because it's straightforward. But if you have to have a differential where there are certain things you have to exclude because the histology looks similar, then yes, you're looking at, by the time you do immunohistochemical stains, maybe some molecular studies, it can certainly take longer. The beginning of the week favors better than the end of the week, because I hate when I get a biopsy on a Friday, because now you got that weekend in between. And it's like, and one of my surgeons, I love her to death. She says, I hate getting bad news on Friday. Can you try to get it out before Friday? Because you don't want to ruin somebody's weekend. And so we really do work hard to try to keep it on the low end of that 7 to 10 as best we can. But some things are difficult and take longer. And every once in a blue moon, for as long as I've been doing this, I'll get a case that I have to send somewhere else for a second opinion. And second opinions, by the way, are not a bad thing. That's a safeguard so that we are doing, so that I am doing as a pathologist the right thing for my patient.
Right.
So if it's something that's super rare that I've never diagnosed, I may know what it is, but because it's so rare and I've never diagnosed it, I want to send it to somebody who's seen 10 of them.
Right.
So that I know I'm on the right track.
Right.
You know, and it does happen. Every once in a blue moon, it does happen.
Can you?
Yeah.
Oh, sorry.
Go ahead. Oh, I'll just make a real quick comment about the second opinions. It's funny because, right, like everybody knows when a pathologist gets a second opinion because you have to send it out. But when I was seeing patients, and I'm sure Wendy can attest to this too, it's like I was always asking people questions, but I would just send an email. I don't have to send them the whole tissue, so it is something very common that every treating oncologist does as well. It's just that you don't have to send a block that somebody has to then look at and send back. So it is very common that we all do that. Even if, right, we know what it is, we still want to make sure, that we're doing the best for that patient,
Yeah.
And then go ahead, Wendy, with your question.
Point. This is a really good point, Lisa. We talked about this a little bit with Dr. Andrea Hayes Jordan about second surgical opinions and whatnot. And I think just as a whole, for our listeners who are largely family-based listeners, I think it sometimes people think that we don't ask questions when we're, maybe don't know the answer or we're unsure, but I cannot think of it really like a day in my life of clinical medicine where I'm not just kind of running things by people.
Yes,
I mean, it's 9:30 a.m. here, and I already talked to 2 people about some events that happened overnight and said, this is what I did. Like, would you have done anything differently? So I think I want people to be reassured that at least I could speak from a pediatric oncology colleagues, is that we really just want to do the best for our children and our patients, and that includes getting the right diagnosis and getting all those opinions lined up. So I think that's a really important point. Not CTOS last year, CTOS last year was in Japan, and I didn't go, but I was watching it on Twitter. I know I was in Washington, D.C., and I saw all these tweets about how many different types of sarcomas are classified now. Tell us how many we're up to, because I think it's important for our listeners to know that all sarcomas are not created equal, and there's a lot of them.
Yeah, I don't even know the exact number. And I will argue that of the exact number, I've probably diagnosed every single one of them at least once.
Wow.
And sarcoma, we say sarcoma like it's a thing, but it's this heterogeneous family of tumors. And it's, if you start thinking that there are tumors that make bone, there are tumors that make cartilage, there are sarcomas of fat and sarcomas of muscle and sarcoma of tissue. We don't even know what kind of tissue it is. And the thing is, as we do more molecular studies, we find more tumors. So we have the sick associated tumors. Sick DUX4 was the most famous of that group, and the B core rearranged tumors. And now an EWS, which it's so funny, is one of the most promiscuous genes out there. I've lost count of how many tumors translocate with EWS and something. And we're finding more and more every single day. So it's important for everyone to remember that if you say, I have a sarcoma, the knee-jerk reaction of a pathologist, somebody like me will be like, oh, but which one? Because saying I have a sarcoma doesn't mean a whole lot. Suddenly there's like 300 diseases in my head that could be what that is. It's like, which one do you have? Because everyone's treated a little differently. And that's why, when I brought up before this, the small cell osteosarcoma versus the Ewing sarcoma, those treatment regimens are completely different.
Right.
So it is important for me to be right so that you know what to do to get the right chemotherapy. I mean, that matters. So the list is growing every single day. I actually just bought myself as a gift to self. Well, I bought myself a Nintendo Switch too, but I also bought myself.
Nice.
I should not have done it. I bought myself I'm telling you, the latest WHO bone and soft tissue tumor classification. This is I think the 4th one that I've bought since I've been in training, because
probably
the tumors,
cost just as much as Nintendo Switch.
No, it didn't. It's cheap. It was way cheaper. I'm lucky I found a Switch in the pandemic. See, I should have done this before. It was like trying to buy a swing set. We bought our swing set at the beginning of the pandemic. Thank God, because had we waited 2 more weeks, there would have been no swing sets left, and our kids would have gone nuts this summer. So that, but getting back on topic.
Yeah, I'm
There
sorry.
are just so many, no, that's my fault. There are so many sarcomas out there. And I think we have to be wary. So when people reach out to me on Twitter, and I've had lots of patients reach out with their stories, and thanking me for doing what I do. And I was like, no, I thank you for sharing your story, because I think the patient's perspective is actually much more important. I did tweet once that sometimes I cry when I read my cases. That is absolutely true. I ran into a young man with his parents who was picking up his slides a few years back. He had a Ewing sarcoma. He was a teenager. He was absolutely adorable. And I had to just I had to excuse myself. I literally went back to my office and I started sobbing. So I'm like, why does that happen to these kids? And it makes me go home and hug my babies tighter. So like, thank God for you guys, for what you do. I could not be the oncologist facing them. It's hard enough for me just reading the slides, because I get emotionally attached and I'm not even seeing the patient most of the time. So
well, our patients are pretty awesome. I can't deny that. I love all of my patients. I know Lisa does too. And it can be hard. I mean, that is a hard part of our job, but we're just so thankful for people like you and the rest of the crew that helps us take care of them. And it's really humbling to take care of these families. I think that's like the best word I can use to describe it. Go ahead, Lisa.
Oh, I was just going to make another comment that, actually, I almost brought that up earlier, because I was going to say, when Wendy was talking about having a close relationship with her pathologist, when I saw patients, I did the same. I knew all the pathologists, and I'd go visit them in the basement where they're always stuck. And one thing I did really, what I was going to mention was that I really want to bring to light too how much heart everybody has, because the pathologists that I worked with felt the same. Like it meant so much to them, of course, to make the right diagnosis, because they weren't just seeing tissue, they were seeing that patient, because just like you said, they had read their history, known that it was a person this age, a boy or girl, and and they would always ask me questions too, like, how are they doing, how's the family? It really is something that you do with your whole heart. And I think that's what's so amazing about you being on Twitter, is that people can really see that. They could see that how much heart, and you're letting everybody know not only how important pathologists are, but how much heart they have. So yeah, awesome.
And I think that the equivocal, when a patient relapses or something comes back, or maybe grows through our treatment, when my pathologist calls and says, yeah, it's confirmed this is a relapse, if I have questions because I can't tell in the imaging or whatever, it's almost as bad as when I had, like, they feel so bad when they call me and confirm that has happened. Mm-hmm. I imagine it's as bad as, when I have to tell the family, because we all do just care about them so much. And so having a good pathologist is worth his weight in gold for sure. Yeah. To get into the nitty gritty of pathology, you mentioned, so we were talking about the subtypes and we got a little bit off track, but we mentioned molecular changes, we mentioned IHC, we mentioned karyotype, all these big glibbity globbity words. And so can you give me the elevator description of how IHC works and what that means? Just like color, staining, and that sort of thing.
So IHC is also known as immunohistochemistry. And immunohistochemistry, what we're doing is applying antibody labeling to tissue to let us know whether or not the tissue is producing a certain substance. So I guess the best example, I'm trying to think of something, a good one. Okay, so like with Ewing sarcomas, the most common translocation in a Ewing sarcoma, because we know there are 2 chromosomes that have pieces break off and move to other chromosomes, which isn't supposed to happen and is not a great thing genetically. And so we know the most common translocation is an 1122, which is an EWSR1 to the gene FLY1. And we can exploit that. If I suspect something is a Ewing sarcoma, I will take the immunohistochemical stain for FLY1, which, pathologists, if you're listening, I know it has more uses than Ewing sarcoma, but I'm trying to keep it simple. I was just like, it's also a vascular stain. So, and it is also a vascular stain. Let's keep it simple. So I'll apply FLY1, I'll order FLY1 in our little fancy computer system, and then that antibody is applied to the tissue. And if it's positive, it'll stain a certain color. So some people will use what we call a red chromogen, and the immunohistochemical stains will be red. A lot of people use brown chromogens. So if it's a positive stain, it'll be brown. I like to say it looks like, if it's something that's positive, it looks like something pooed all over the slide, because we use brown chromogens for the most part in our labs. So, you'll have all these brown nuclei that are positive, because that antibody is being produced in those cells. And that nucleus stains, and it's a beautiful thing. And so we use panels of these stains, sometimes 4, 5, 6, 7 stains at a time, to include a diagnosis and exclude others. So that's one of the ways that we can, what we call, work up a tumor to get to the proper diagnosis. Does that kind of answer the question?
Yeah, absolutely. And I think, when me as an oncologist, when I first started practicing oncology, I would get the reports and I'm like, oh my God, what does this mean? But now, this is all I take care of is sarcomas, and I know kind of the panels that you guys use and what we're looking for, but that's always evolving. So things are coming out new. Like now we check for NKX 2.2 that's, more specific for EWS, FLY1, et cetera, and Ewing. So it's an evolving field of medicine and technology as we learn more and more about these tumors. And I think that in addition to the genomics, which I'm going to ask you to explain next as a warning, but I think that's helping us parse down more and more and be more specific about what type of tumor you have, because now it's not just small round blue cells not otherwise able to be classified as small round blue cells with blah blah blah. I think we're still scratching the surface, and we're going to find out more and more. But now I've warned you that I want to ask for your elevator explanation of what does, well, let's go back to, like you said, the cells can be grown and karyotyped. So it seems kind of weird if you've never thought about taking a tumor tissue out and growing it and then looking at it. Can you explain how that works?
So, in order to do a karyotype, right, like our DNA sits in our cells in things called chromosomes. The chromosomes aren't usually just hanging around free float. Well, I mean, they can free float, so let me not say that. We won't get to the whole cell-free DNA thing, not today anyway. In order to look at the tumor cells, in order to look at the chromosomes in a tumor, you have to actually grow the cells so that you have enough of them, and then lyse them to release the chromosomes. You can look at the cells if you want to do FISH, but in order to look at the chromosomes, you need to actually burst the cells so the chromosomes are available to look at. And then we have people, cytogeneticists, who literally will sit down and assemble all of the chromosomes. I mean, they do this better, I think, than almost every pathologist I've ever met. But they'll sit down and actually take all the chromosomes and pair them up. And they can look at these chromosomes and tell if bits of genetic material have moved from where they belong to where they are now. And that's how we identify something that we call translocations, where you have transfer of chromosomal tissue from one chromosome to another. We have 46 chromosomes normally. So we're looking for lots of different, when we look at a karyotype, we're looking for differences. Are there more or less than 46 chromosomes? Because that will tell you something. Have little bits of material moved from one chromosome to another? That's how we can identify translocations, which may allow us to identify a tumor. Now, sometimes we can't do that easily with a karyotype, and that's where genomics comes into play. Because some breaks are just too small to see on a karyotype. The resolution isn't high enough. But if we can sequence a tumor and look at the entire genetic profile of that tumor, not only can you find what genes are affected, but you can also potentially identify targets for therapy. And so it's not unusual at all for our oncologists to ask us if we can have a tumor sequence, particularly, I don't want to cry, but particularly in patients who recur, who have failed the initial therapies for a tumor. Because then if we find something else to target, we might have another shot at saving that patient's life. So tumor sequencing has become immensely important. Karyotyping is more of an old school method. I love it because it in some cases it works really well, but I've also become very fond of sequencing because there's so much we can do to help patients if we can find an actionable target, or an actual target being a gene that we can direct therapy toward. So it makes it worth it.
Yeah. And I think, kind of piggybacking on the conversation that Lisa and I had last week with Brian Crompton about research and whatnot, and some of these sequencing efforts are done in the context of clinical studies. And even if there's not a targetable mutation or change for that specific patient, the more we learn about all of the tumors, the more that we can inform the people that make the drugs and kind of just keep chipping away at this and moving forward. So I think we're all hopeful, I guess is the word I would use. You know, we don't have the Gleevec of sarcomas just yet. Well, larotrectinib, maybe larotrectinib is the Gleevec of sarcomas for infantile fibrosarcoma.
Just does have Gleevec.
Anyway, so that is very helpful. And I think, you know, even if you don't understand all the nuances of this conversation, I think just talking about it and listening to how much work goes into a diagnosis is helpful to families to know that you guys aren't it's not just sitting in a queue waiting for your eyes to look at it, that things are being done every day that tissue is down there, and that you know, all these studies are being looked at, and they're so amazingly complex and intricate to get to the right answer. So I think just hearing that is helpful. Lisa, I always talk too much. Go ahead.
Oh no, I was actually going to ask if you could break down just one more thing, which was fish, because I always wonder what people, what people who are in medicine think when we're always talking about fish. They're like, are they going fishing? What are they talking about?
We are going fishing.
I know.
So I'm trying so hard not to laugh through all this, right? And you guys make me have too much fun. So fish is also known as fluorescence in situ hybridization. And, you know, and it's essentially hybridizing antibodies to, you know, to fluoresce to identify a mutation or possible partner change in tissue. So again, you know, anything with a translocation is a great candidate for fish. My love in fish, I mean, there are lots of things you can do with fish. You can look for amplification. So if a tumor is making too much of a gene, and that may be an actionable target, so that's important. We also use, I love the break apart probes, what they call split signal probes, where you can actually, now, it's interesting because with a break apart probe or a split signal probe, you can track that a gene has moved from one chromosome to another, but what you can't track is who the partner is. So in that sense, with a split signal probe, you know, fish, it only gives you half the information, but honestly, if you're doing fish for a specific gene, you're probably 95 to 98% of the way there already. And you're doing it as more of a confirmatory test, which is pretty much how I use my fish. I don't just pull it out of the hat like, oh, let me run, you know, 5 probes on something. I don't. For sarcomas, it's really not necessary for the diagnostic part of it. You know, it's interesting to look at things later, you know, again, for actionable targets. But in terms of diagnosis, I don't usually need to pick like 5 split signal probes to figure out what I'm looking at. I'm usually most of the way there. Like synovial sarcoma is a great example of that. You know, most of the time, I've got an immunopanel lined up. Now, I'm not going to toot my own horn here too much, but a lot of the time now, because I've been doing this for over a decade, when I see a synovial sarcoma, I almost know it's a synovial sarcoma, and I'm talking about the monophase ones.
Sorry, that was my pager.
I was going to say, didn't hear it. You did it in perfect timing.
Yeah.
So you know, so in that case, if I look at it and I have a feeling it's something, I'll send a piece of fresh tumor for fish at the time of the frozen section, if I'm that sure. Because then I can take the diagnosis of a synovial sarcoma down from like 7 days to 3 days.
Yeah.
Patients are much happier finding that out in 3 days. So, so, you know, it's a very helpful study. I'm glad we get to do it. I love it. I love my genetics people. They just, and the molecular people are like, I love these people. I really, really do. But you know, it's another test in the arsenal. Yeah. And I hope I'm explaining this okay. You know, it's so funny when I'm explaining this. I'm trying to not be super technical as I'm explaining it, because I know there are people who are listening who won't be physicians and don't do this. So I'm hoping I'm not being too technical.
No, don't worry. I'll just keep on asking you to break it down. But no, you're doing great. Thank you so much. And then, you know, while you were talking about, I was thinking about a couple different things. But first of all, about the amount of tumor tissue, because I know we talk about that a lot, especially if a patient does have the cancer come back again, you know, then if they do enroll in a study, or if they did at the beginning, there's not enough tissue. Can you explain, like, how much tissue do you need, and why is tissue always an issue?
So You're a poet and you didn't know it. It depends. And there's what I always say, there's what the pathologist thinks is a lot of tissue versus what everyone else thinks is a lot of tissue. So I get like, radiology colleagues, please don't kill me. Sometimes we'll get 3 skinny cores and they'll be like, that's plenty of tissue. And I'm like, oh no, it's not. Because the reality is I may need to send things in that moment for genetic testing. But the thing is, it's really important to have untreated tumor tissue down the line.
Yes.
Because once the patient has chemotherapy or radiation, the biology of the tumor seems to change. So what it may have responded to initially, a tumor, if it recurs, may not respond to the second go around. And so, it's important for us to be able to say, we may need to do this genetic study again. I may need to sequence this again because now it may be different. And so, a lot of tissue for me, like if you give me, 2 small pieces on a telephone, I'm going to tell you, please go get me more. Please, please, please. I can freeze some and bank it. I can, send for the genetic studies. I know I'll have enough to make a diagnosis. 3 skinny needle cores is not going to be enough. So help me, help me, help me. My orthopedic oncologists, I have to say, have a very good understanding of that. And so I always say they're very generous. And again, it's also important to remember that when they do a biopsy, they don't want to violate their operative field. So that's the other. If they have to come back and do a surgery, they don't want to create a situation in the biopsy where it's seeding all over the place. So I also have to be, cognizant and respectful of what their operative field might be, what their situation might be, so that my requests for what I think I may need don't jeopardize the health of the patient. So it really is, there are very few teams in medicine where I can say where a sarcoma team is one of the strongest units I've ever worked on, because we all communicate with each other all the time. And I think that, I guess being a former athlete, I love the team sport of it. So it's like, I love being able to have the conversation with the oncologist about what they're seeing, what they're thinking. I love being able to talk to the surgeons about what they're seeing in the moment in the OR and reading the chart, putting everything together, and then on occasion, meeting the families and seeing it from their perspective, because people do come to their slides. And
that's so great.
And I do get occasionally I do get to meet the families, and my secretaries know, like if they know a family's coming to pick up slides from my case, I tell them, call me. Because if I'm in the building, I want to come talk to them. I want to see them. And I've done that several times. I've had people hug me, thanking me for what I've done for them. And it's just, it warms your heart, because we don't get that much in pathology. I wish I could see.
Right. You need more hugs.
I've sat down and showed people their slides. It hasn't happened often. And of course, it's after they get their diagnosis. But it's nice because it gives the patient it gives them that 360. They get closure because they can see what they're battling. And not everyone understands what they're seeing, but they feel like they're part of the process. And I think that's really, really important. So I wish we could do more of that.
Yeah, I've had quite a few kind of preteen, teenagery kids ask me to see their tumor. And so I always appreciate it, because I'm, just generally hand waving, like, oh, you see all these purple cells and they all look the same. They should not all look like this.
So I do it too. I know. And I think that's so true about the team. I was just talking about that the other day with pediatric oncology, and I feel sarcoma is the same way. And that's what drew me to pediatrics, and I think to sarcomas, because it's like, I love being able to have all different team members and working together, and trying to problem solve together, and everybody using their own strength. And it's such a powerful, meaningful, situation where you're just like, you feel like you're really, making great change and going towards something, making a difference.
Tour de force, for sure. Yeah.
Yeah.
I got all sidetracked when I answered a page. I'm sorry.
Oh, I mean, I can ask another question, but I was going to say, did you have something else, Wendy? Oh, okay. So then my other question was about, where do you think, or how do you see the future of pathology, and how do you see it changing from like when you were training? Because, for example, like I see, it was so amazing in tumor boards when like the pathologists, they just take a picture and show us, like, we don't even have to bring their microscope anymore. But I know that like when you send for a second opinion, do you still always have to send the slides, or can you just send the picture? And then just in general, where do you see everything going now with molecular and genomics, and how is training changing and all this?
So I think, a couple of things to unpackage there. In terms,
I know it's a lot.
In terms of sending things, I mean, you still have to send glass slides to people and occasionally blocks for second opinions, because we're not at the place yet where we can digitize images. I think we all pretty much do it now, particularly in academia. When we put things into a slide scanner, now you have banks. So instead of, I haven't been out that long, but when I was training, everybody had slide sets. I mean, I still have my slide sets from when I was in training, but now slide sets can be, you can stick something in a slide scanner and you're creating slide sets digitally. So your residents aren't stuck sitting in their office at a microscope in the hospital to study. They can study images at home. They can study images on their iPhone. I mean, because there's so much more out there that's digitized now. So I think the digital revolution, artificial intelligence, AI, informatics are areas where pathology is really blossoming and growing, and we can't deny it. Do I think that AI is going to fully replace human pathologists? I don't, at least not in my lifetime. I still think there's value to holding glass in your hand and reading a slide. I think there will always be value to that. Unfortunately, we're not seeing it as much in medical school curricula anymore. So we have people coming into pathology residency who legitimately have never read a slide in a microscope. Because in medical school, it's not done as much as it used to be. The ones who rotate through our departments, obviously in pathology, yes, they read slides. So they, at least seen a slide before they get into residency. But, when I was in medical school, we had a histology course. We used microscopes in our preclinical years. It doesn't happen anymore. So we're seeing that change from the glass slide to the digital, but I think there will always be a presence for glass slides. Molecular is playing a huge role. And a lot of it is because of patient-centered medicine. When, I can take a single patient's tumor, sequence that tumor, and say specifically in this patient, this is what has meaning for you. These are the genes we can treat. These other 85 don't mean so much, goodbye. We can do so much more on the molecular sphere than we were doing even 10 years ago. Well, okay, now it's been more than 10 years since I finished training, but we can do so much more.
Yeah. And
molecular really is a part of the future, but morphology drives the molecular. I can't stress enough. I mean, the thing is, you just don't want to start throwing tissue at things and just let's do every test and see what we find. That's not useful or helpful to a patient. So at least if I know what I'm looking at, I can say, all right, we can look for, these 3 or 4 things. Let's try to target. We know what's out there, and as Dr. Rhodes said, it's not just targeting things for that particular patient. Once you have enough data, you start to find trends. That's how all the big studies get published. So after you get enough cases, you start to find trends in tumors that look the same. And all of a sudden, boom, you've discovered a new tumor.
Yeah.
So, that's molecular is extremely important, but it won't replace. I don't think anything will replace histology. I think everything will run alongside with it and be very useful adjuncts to what we're seeing under the microscope.
Yeah, you still need that foundation and that base, so then you can grow from there. Yeah.
Do you mind if I switch gears a little bit? I don't know if it's going to transition well when you podcast it, but so I ran into you on Twitter through a Sunday night chat, which I don't think is really going on anymore. At least it's during bedtime or something, and I can't do it. But it was a Twitter for women in medicine, right? That's what it was. And you and I had kind of connected because I saw your thing said that you were a sarcoma, a bone sarcoma pathologist. And I was like, that's my people. And we've had several conversations about women in medicine. And I know that is another one of kind of your passions is women in medicine. And particularly women of minority backgrounds, people of color, et cetera, et cetera. And so I wanted to just touch on that a little bit. And I wanted you to just say whatever you wanted to say about that we're obviously all women in medicine and we could talk for another 5 hours on that. But you've had a really public and vocal voice about your experience and how you're trying to train the next generation, which is what brought this up as you're training your people, and really just trying to be more inclusive about medical training, because we know historically it's all been white men. And now we are definitely seeing more women, but still we are not representative in medicine of our population as a whole. And so I just wanted to give you a little bit of a platform to speak on that if you wanted to.
Well, thank you for that. One of my biggest passions is the pipeline in pathology in particular, because what I have seen and what I've witnessed over the years is that particularly for pathologists of color, we are a very, very, very small number of pathologists overall. You know, I mean, in terms of numbers, I think there's only roughly 130 or so practicing Black pathologists in academia. So that's not even one for every medical school in the United States.
Yeah.
And then there's only about 330 or so Black pathologists who are boarded in practice in the United States. That's a ridiculously small number when you consider the number of Black people in this country.
Yeah.
And so, you know, a lot of it for me has been trying to debunk the stereotypes of pathology. You know, pathologists get a pretty bad rap out there. You only like dead people. Well, we do have forensic pathology, and yes, that's a very important part of our specialty because we need people to point to how and why people died. We need people who can look at the human body critically to determine what's gone on in that patient, particularly, you know, in homicides and accidents and things like that. It's very, very important. And it's an important part of our specialty, but it's also a small part of our specialty. You know, the overwhelming majority of pathologists are in the community setting. And it's something like a good 80-something% of pathologists practice in community hospitals. You know?
Yeah, I didn't know that.
Most pathologists are in community hospitals. That's why the academic numbers are so low. You know, it's only about 10 or 15% that are practicing in academia, and then you have another 5% that are in industry and research. So the overwhelming majority of people, boots on the ground every day, are in community hospitals. And so, you know, the opportunity for a medical student of color to see a pathologist that becomes of color becomes very low. There may not even be one in the department in their school. So, you know, for me, the pipeline has become really important, and looking at how can we convince little girls that medicine is where they want to be? How can we convince, you know, minority children that medicine, and particularly pathology, is where they want to be? And so, you know, I love going out into the community. I go to schools. I've talked to 4- and 5-year-olds about pathology in a way that it's like, wow, that's what pathologists do? Because people, you know, we talk so much about anatomic pathology, and people forget the clinical pathology part of it. Running a clinical lab, I'm also a medical director of a laboratory, you know, and people forget that, you know, if you go to LabCorp and get your blood drawn, there's a pathologist behind everything that happens after that. If you go to, you know, if you pee in a cup, and I mean, people laugh when I say that, it's like, if someone's analyzing your urine, there's a pathologist behind all that. There's somebody in charge of that. And so I'll go to school and I'll say, okay, kindergartners, how many of you had a needle in your arm and had blood taken out? And they all raise their hand, because by that point, they're 5 years old. They better have had at least one lead level done. So they all have.
Right.
You know? And then I'll explain, I'll say, well, I'm the kind of doctor who looks at your blood and makes sure there's nothing wrong with it. And their eyes get so big because like, ooh, doctors do that. And if we start early and we normalize what medicine can look like, by the time they get to medical school, you know, or by the time they're in college and they're considering it, they realize that medicine is a viable career choice for them.
Yeah.
You know, one of the things that I've been so fortunate to do, although I'm sad that I won't be doing it anymore because I've taken on this interim chair role, now my life's completely changed. But you know, for 5 years, I was a course director for a first-year medical student course in musculoskeletal and skin disease. And my co-course director, because there was 2 of us together, was a PhD, and she's a Black woman who has a PhD in cardiovascular physiology. And so when we would step to the front of the class, you know, particularly the minority students, you would see the awe, because it's the only time they will see this in their entire medical school career, where 2 Black women are standing in front of the room running their course. Yep. And that's got to change, but it's difficult to keep. It's difficult to keep underrepresented folks in medicine in academia, because academia is not always kind.
Yeah. And I think, you know, and I don't know if this is the right answer, but this is something that I try to do. And if we have any listeners that are, because we've gotten emails from people who are interested in going to medical school and interested in, you know, oncology and whatnot. Kind of with everything that's been happening in our country, with the very much delayed but very needed light upon racial injustice and inequality, and you know, talk about being an anti-racist and how do we do that. I had this moment before I left where I was working with somebody who was a student, and she was great, and she was working on one of my projects. And I thought, gosh, you know, she would be a really good doctor one day. And she had mentioned to me that she was thinking about going to medical school. And it can be very simple things that we do as people in academics. And I emailed her and I said, hey, if you ever need a letter of recommendation, I'm happy to do that for you, because our interaction wasn't so close that she probably would have asked me. And I don't know if she'll ever, you know, follow up on that, but I thought, you know what, I'm just going to put myself out there and offer it. So if she needs somebody, I'm here for her. And I think that's one way that, you know, people in academics and people in medicine can really support and be an ally for people that are so deserving of these opportunities and will be phenomenal physicians and practitioners. So that's just, you know, just what I decided to do. I don't know if it's the right answer. It's probably not the only answer, but I think those things are important, to just put ourselves out there and offer our support to young people. That's
I'm so sorry, I'm cutting someone off, but I also think
that's all I have to say about that. That's a little instance of I think, you know, the recognition that we have a problem. We're not representing our population as a whole, whether it be the gender lines, racial lines. I mean, we need to be better, and we need to support and recognize that it's happening.
I mean, I absolutely agree with you. And there's so much we need to do. You know, I'm grateful that I've been able to find my voice and to be able to do it in a respectful way. I think the respect is really important. You can make points without being nasty. We can agree to disagree. You know, one of my biggest hangups about social media, as much as I love it, is when you bring up these kinds of things and the trolls just come out. I mean,
Yeah.
I hit the block button more in the last 24 hours than I think I have like in the last year and a half. But I saved all the screenshots. When I do my next talk on social media, people can see what I go through. Because
No, that's good.
Because I think people need to see what's out there. You know, it's like I made a statement that was not at all negative, that I'm basically saying, you know, I fear for my people because we're not seen as of the same value as other groups of people. And the responses, I mean, of course, there are people who are very kind and supportive, but then you get the other side where nasty things are said, and you're just, you know, nobody asks for these horrible things. Nobody. I'm a Black woman. I always say I was Black when I was born. I'll be Black when I die. That is the one thing in my life that will not change. Anything else can change. My weight will change. I'll get bigger, I'll get smaller, I'll get bigger, I'll get smaller again. You know, my hair, I can change my hair. You know, but I can't change my skin, and I wouldn't want to. This is all I know. But I wish that people wouldn't look at me and immediately assign value based on how I appear, because you don't know me until you get to know me. And I just think it's so unfair what we go through as a people. People immediately, oh, Black person, clutch your purse. You know, it's like, give me a break. Most people, like, I have no desire to ever grab somebody's purse and go running down the street. No desire whatsoever. And to assign that kind, you know, of bias toward a group of people, it's exhausting. It's truly exhausting. But I hope, you know, I appreciate those who are out there, you know, using their voice and making a difference. I appreciate the allies, but, you know, I agree. It's not enough just to say, you know, we don't agree anymore. I mean, a true anti-racist stance is what's needed these days.
100%. And I think, you know, I am an oncologist. I take care of mainly sarcoma patients. We have a lot of things that we need to do to improve that. A lot of my patients don't have good outcomes, unfortunately. And so I always tell my patients I was born somebody who really tries to be an eternal optimist. I know these times are hard, but what cancer has shown me is that I still believe that the good is there and we can cultivate it, and together we will. I truly believe that. And I think it takes people that are, you know, we have to do, and I mean, we at the top, we have to do the heavy lifting, and make this conversation happen and move it beyond conversation to action. And so I still believe there's a lot of good people in the world because I see it every day. So that's
and
I know how to live my life.
Yeah. And I think to that point, Wendy, it's like, as white people, we need to do something, you know, like we can't expect Dr. Fitzhugh to keep doing all the work, you know, because all Black people are exhausted, and we need to do the work by doing the research first. You know, I think that's the biggest thing that I've learned over my journey that I wish would have started way earlier. A few years ago, I read White Fragility, and I was embarrassed about how much I didn't know and didn't recognize. And I think, you know, that's what is so important, is that white people read, learn the history. We don't learn it in school. You need to know what's going on, and then you will start recognizing your white privilege all over the place and how you need to make a difference. So, you know, and I thank you so much, Valerie, for using your voice, because I can't imagine how exhausting it is.
Yeah.
And
Social media is definitely a double-edged sword.
Yeah, and I know, Wendy, you have to go, but I have to ask Dr. Fitzhugh a really important question, because
I know what it is.
Oh yeah, I mean, I want to know what's going on, like if Bubba Wallace talked to you first before he left, and then if you knew about him and Michael Jordan, like, I mean, because they're like BFFs, you guys. Like, she is celebrity, her and Bubba.
I know.
Like this.
We're not worthy.
Yes. We are such fangirls.
Like, I have to tell you, it's so funny because every time I do a podcast now, I'll DM and be like, just so you know, we talked about you again. Sorry. You know, that was a really fun thing. So no, I did not know about the MJ Denny Hamlin deal before it went down. I'm not important enough to know those kinds of things. And never will be.
Not yet.
You know, I have to say, like, he is just like the nicest, realest dude ever. I'm still touched that he followed me on my birthday. I mean, that was one of the greatest things I've ever seen Med Twitter do. It was like, I typed this thing as I'm going to bed the night before my birthday, like, I want Bubba Wallace to follow me for my birthday. And it caught fire and just like took off. And I have to admit, I've been watching NASCAR since I was like 11 or 12 years old. It's not a new thing for me at all.
Right.
And which, you know, people are like, oh my God, really? But I love a fast car. I love the idea of it, and just watching people. Like, I really want to drive a pace car one lap before I die. Like, seriously, not that that's happening anytime soon, really. And so he was nice enough to follow me, and every once in a while I'll send him a direct message. He does actually answer them. He's just such a nice guy, and I'm really hoping that one day I will get to see him in person. I'm not seeing any sports in person right now because COVID-19, and I'm really excited that my team, Go Jets, did not force us to buy season tickets and aren't having us in the stadium this year. I think it was the right decision and the right thing to do. So, yay, Bubba, by the way.
Yay.
I knew I was like, Lisa's got to ask about Bubba.
I know. I was just waiting. Oh, thank you so much. Thank you for speaking about all the things, pathology, but especially being a Black woman in medicine and how you're a powerhouse. We love you. Thank you.
Thank you. Thank you so much for inviting. This was awesome.
Thank you so much. And we will see each other on Twitter and maybe one day at conferences when we can do it again.
I know.
I hope so. Otherwise, it'll be virtual. Well, I'll see you guys in boxes.
Exactly.
Just in boxes.
All right. Thank you guys.